this talk for Dr. Wells, who did much of the work for this study. We'll be working with the Children's Cancer Survivor Study Group. No disclosures. This study objectives were to evaluate the late onset adverse neurologic outcomes in survivors of pediatric brain tumors, determine the pattern of onset, the cumulative incidence, and the risk factors. This is off the CCSS population study, which actually is an old study that is going to be updated, but initially collected patients between 1970 and 1986 who were 5-year survivors of childhood brain tumors. Patients had to be less than 21 years of age at the time of diagnosis, and there were 26 centers throughout North America. And a very important thing, there was a civilly controlled group. The questionnaire methods were updated in 1994, 2000, and 2007 for self-reported late onset neurologic and neurosensory abnormalities. Treatment for all the baseline information were actually extracted from the medical records, and then analysis was done. These were the outcomes and covariants that were initially looked at in this large population. This is the age and time of diagnosis of the survivors, and as you can tell, the majority were relatively young at the time of their initial treatment. This is the age at their last completed follow-up. So we're finally looking at patients that are really out into their mid and late 30s of what these patients suffer as time went on. Now, as you might expect in the 1980 to 1970 to 1986, we did not have an overrepresentation of survivors with PNETs. That's how that was listed. Obviously, in the new cohort, it'll be broken down for meninoblastomas and others, but we were working off the pathologies that were outlined back at that period of time. The treatments, once again, this is a different kind of cohort because many children who needed very intensive therapies did not survive, so there was an overrepresentation compared to present cohorts of surgery alone or surgery plus radiation, and less children, about 25%, actually received chemotherapy and very few chemotherapy alone. This is the overall survival rate, and this is obviously one of the more worrisome factors. Survival rate for the whole cohort, when they're hitting the mid-30s, is only 75%, which is much less than what you'd expect in the normal population. And the listed reasons for the deaths were recurrence of primary cancer and second malignancies. We really don't know how many of these recurrences were really second malignancies. We think that's an underrepresentation. This is the other very worrisome factor. If you take a look at these patients over time, see how coordination problems, headaches, seizures, and motor impairment, they all increased for 5 years after diagnosis down to 20, 25 years. So there was no plateauing of the curves. Looking at this, tinnitus, dizziness, hearing loss, slight but significant increase over time. Legal blindness, this was a little bit of a harder thing to interpret. We did not see as many new cataracts. Remember, a lot of these patients had them relatively early, and retinal conditions not been a big problem. Looking at risk factors, we wanted to look at late onset seizures, and again, radiation comes out as the major risk factor, especially radiation greater than 5,000 rads to some part of the temporal lobe or to the frontal lobe. If you take a look at late onset problems with coordination, balance, or tremor, similar higher risk factors with radiation, but obviously recurrence of secondary malignancies also impaired these patients. And the risk factor for late onset focal weakness, and this is very worrisome, is thinking, look, why do patients get weak, or why do they get uncoordinated later in the course? Again, a relationship not only with recurrence of secondary malignancies, but independent with the radiation they received. Looking at that sort of schematically, we did break the radiation with the help of the radiation oncologist and dosimetry into 4 different areas. And you can see when patients received less than 5,000, they had problems with coordination and balance, but maybe in coordination and balance, but they had similar problems greater than 5,000. So even though 5,000 did increase the risk, the overall concerns were about the same. The question about tinnitus was obviously an issue of higher doses of radiation and this was in the pre-cisplatin era. We looked at multivariate models to take a look at what are the effects of late occurrences on the late quality of life of these patients. And stroke double the risk for seizures, 7-fold increase in coordination, and not surprisingly, a 15-fold increase in weakness. Stroke minimally affected other factors, but was really an independent, important factor, and is a pathway from late neurologic, from an acute neurologic effect that is a late effect to late problems. The relative risk compared to siblings is significant, not surprisingly. If you take a look, clearly more seizures than siblings would have at age-matched controls, coordination problems, all of these kind of problems. And as the population ages, obviously older responders have siblings who are also older, and they pick up problems. Some of this relative risk falls apart a bit. It's still there. So our conclusion is that late onset neurologic deficits continue to increase 30 years after diagnosis. This was a questionnaire study. It could not really address the issue that people have raised about early onset dementia, early onset aging in these patients. And please remember, this was a cohort that was, although it was treated with radiation alone, and you could say for many of them that the radiation has gotten better, this cohort did not see a lot of chemotherapy. It did not see cisplatin. It did not see other agents. There's going to be a trade-off in this cohort as time goes on. The substantial contribution of radiation agrees with previous CCSS reports and continues the trends. Tumor recurrence, secondary malignancies, and strokes were strong but independent predictors of late effects. And I really do think this balancing between what was a tumor recurrence and what was a secondary malignancy is significantly variable, depends on how it was reported. And this is a questionnaire, even though we had the information from these patients, what their initial tumor was by chart review. Certainly it was more of a information given to us by families. And that the risk of adverse neurologic conditions is higher than siblings. Support for ongoing screening, the need for these prospective clinical evaluations and interventions, determine if the risk of toxicity has changed with modern therapy. Within the next 2 years, we'll have the cohort analyzed that goes between 1986 and 2000. It won't be perfect, but it will give us the so-called modern era of chemotherapy, which hasn't changed dramatically, and better radiation. And this is the Children's Cancer Survivor Study, which is an NCI-funded resource. Dr. Wells leads our effort, but this is really a national NCI effort, and that's the website if anybody wants to look into greater detail on anything that's come out of the website. Thank you.